My name is Dr. Susan Dent. I'm a medical oncologist at Duke Cancer Institute in Durham, North Carolina. I'm the co-director of the Duke CardioOncology program, and I'm also currently the vice president of the International Cardio-Oncology Society and past president of the Canadian Cardio-Oncology Network.
And hi, my name is Dr. Christine Bresden-Maisley. I am a medical oncologist at Mount Sinai Hospital in Toronto, Canada. I'm also the medical director of the cancer program at the Sinai Health Systems, and I'm the current president of the Canadian Cardio-Oncology Network. So Susan, now that we are at the 5th Global Cardio-Oncology Society meeting here in beautiful Sao Paulo, Brazil, and we've heard some great presentations on cardioprotection, what do you think is the best cardioprotective strategy for example, breast cancer patients who are receiving cardiotoxic medication?
Great question. Thanks for asking that. I think there's been a lot of interest in this area over the last few years. In fact, in the last 2 or 3 years, we've seen at least 5 randomized controlled trials published looking at cardioprotective strategies in breast cancer patients using mechanisms such as ACE inhibitors, ARBs, beta blockers. And in these 5 recent studies that have incorporated over 1,000 women with breast cancer, what we've seen is that 3 of those studies showed there was some protective effect with an attenuation drop in left ventricular ejection fraction, but 2 of those studies showed no benefit. And so it's interesting to try and take that information into clinical practice and what can we do today in terms of when we see those patients. On the heels of those studies, in last month's inaugural issue of JACC CardioOncology, there was a great paper which was a meta-analysis looking at all this randomized studies, looking at cardioprotective strategies. 14 of the 17 studies that were published in this meta-analysis showed some benefit to cardioprotective strategies. However, it really showed only a 4% attenuation in drop in LVEF across the studies. And my question is that clinically meaningful? I mean, yes, we see women experience drops in their ejection fraction, but if it's only 4%, and if the margin of error when you're measuring LVEF can be up to 10%, what does that mean long term? And so I think, moving forward, we have to revisit, are we really testing the right patient population? These patients were heterogeneous across the studies. They tended to be women who were otherwise well with few cardiovascular risk factors. So I think moving forward, this data is interesting, but we need to look at women who are at higher risk, who have risk features, and what can we do to help them? So at the end of the day, I still don't think we can go home and say, yes, we can apply this data to our patients on an everyday basis. For those who are at high risk, who have cardiovascular risk factors, maybe. But we definitely need better, larger trials looking at high-risk women.
Agree.
So Christine, given the fact that, we've heard at this meeting today that we do need to consider cardioprotective strategies, particularly for women who continue to receive anthracyclines. And in your talk today, you said there is certainly those women in breast cancer who are at high risk, including the triple negatives and patients and those with main node positive. Given those women still exist and their anthracyclines are being used also in other solid tumors, where do you think the field is going, and what trials are you aware of, or do you think that we need to do to move this field forward?
So that's actually a great question as well. The patients that are at high risk are not really being assessed independently, and as you mentioned in the meta-analysis, these high-risk patients are actually diluted within very well breast patients. I think we have to look at other things as well. So as you said, organizing a clinical trial with just high risk. Currently there is a trial called SPARE Heart Failure, currently being run by Dr. Dinesh Devanjanathan at Toronto, and he's looking at all high-risk patients receiving anthracycline treatment. So not only breast cancer patients, but lymphoma patients, and looking at whether or not they can intervene with a statin. So I think that's going to be one question. There's going to be a wealth of data, rich data set to actually analyze that population. But going forward, I think we can actually do things as oncologists. We can certainly look at hemoglobin levels, for example. As I mentioned in my presentation today, that we really kind of ignore anemia. And our breast cancer patients who are at a higher risk, that we then myelosuppress and make extremely anemic, we are certainly providing another cardiovascular stress. And we really haven't really identified ongoing biomarkers and ongoing just normal values that we should be following.
I agree, and I think what we also heard at this year's meeting is the value of exercise, and that can't be understated. Certainly, we've talked about it in years past, but now the American Heart Association has come out with a scientific statement promoting exercise for the well-being of our cancer patients during their treatment and following their treatment. So certainly I think that would have a significant impact on the cardiovascular health of our patients.
Yeah, so I mean, putting it all together, identifying patients at higher risk, so what are biomarker strategies, identifying interventions that we can do to actually improve cardiovascular health at patients who are at higher risk. So that can be with medication, with exercise, but also ensuring that we're not doing any further damage, such as the anemia issue. So I think that all in all together, in the next few years, we'll be getting a lot more data. And just to put a last plug, I think in genomic profiling, in a way of certainly identifying patients who we may not think be at risk are actually at risk for cardiotoxicity with cancer therapies. So I think the future is bright. I think we have a lot that we're still doing and going to do, and this meeting actually allows us to put all of our powerful minds together and attempt to have better outcomes for our cancer patients.